Community psychology has developed largely as a response to perceived problems in using other forms of psychological treatment and interventions. The brief history of community psychology is the story of response to needs unmet by traditional practices. The event that is regarded as making the birth of community psychology is the Boston Conference, which was held in May 1965. Many have noted that much of the impetus for its development can be attributed to skepticism and discontent over the medical model of mental health care that predominated in the early 1950s. I will tell you a little about the third mental health revolution. The first mental health revolution talked about the mentally disturbed, and the thing that emerged was that sick people are worthy of humane concern. In the second mental health revolution, the mentally disturbed was seen as psychologically determined and psychologically treatable. In the third mental health revolution, we see a major change from the first and the second revolutions, and the thrust was on social and community interventions. Heralded as the third mental health revolution, or we can call it the third psychiatric revolution, the emergent field of community mental health is proclaimed as being a radical change in the perspective on human malfunctioning and its alleviation as was wrought in earlier times. The claim that insane should be chained, or the claim of Freud when he showed that neurosis was psychologically determined and curable through therapeutic conversations. As consequence of the first revolution, the mentally disturbed emerged as sick people worthy of humane concern. From the second, their condition was conceived as psychologically determined and psychologically treatable. The thrust of the third mental health revolution lies in the quest for the prevention of mental disorders through social and community interventions aimed at their social determinants. Even when viewed more modestly, the hope of community movement is that necessary services can be made effective and available for the total population, including the poor and the alienated, who have benefited least from the prevailing practices. Policymakers join with many mental health professionals in the conviction that the new models of mental health must evolve if the needs of the people are to be served. At the same time, thoughtful critics have cautioned against the dangers of over-enthusiastic acceptance of the newest therapeutic bandwagon. Work in the field has been motivated largely by pragmatic and idealistic concerns with the development of the necessary base of theory, systematic knowledge, and program relevant research, which was thus far lagging behind. In 1965, the Community Mental Health Journal, exclusively devoted to the work in the field, was started. In 1973, two new journals of community psychology were launched. Also, in 1965, a conference which I have mentioned earlier that was held in Boston. It considered the issues in training of the psychologists who work in the community mental health field. In that conference, the term community psychology emerged to describe the field, which included but also extended beyond the community mental health role of clinical psychologists. A division of community psychology was added to the APA, which now has over 1,000 members. Factors which are underlying the emergence of community psychology. Firstly, we will discuss the discouragement with existing mental health concepts, activities and roles as one of the factors underlying the emergence of the field of community psychology. Community psychology emerged out of what Hirsch in 1968-69 has termed as a discontent explosion among clinicians. established beliefs about the nature of mental disorders and their treatment have been called into question. Clinicians have found traditional roles very frustrating. They question whether they can contribute significantly to the vast unmet needs of large segments of the population. The second factor is disenchantment with psychotherapy. Growing criticism from many quarters have shaken the faith of many clinicians in both the effectiveness and efficiency of traditional psychotherapies. Both humanistic and behavioral psychologists from opposing vantage points have questioned fundamental premises. More devastatingly, however, was the claim that psychotherapy had yet to demonstrate its effectiveness as against no treatment whatever. This argument, launched by Eysenck in 1952, led to considerable controversy over the interpretation of the limited amount of research data available. In time, it inspired more sophisticated research studies. In a landmark review of 24 studies that evaluated the effectiveness of psychotherapy, Eysenck argued that the rates of improvement for neurotic patients following psychotherapy were essentially the same as improvement rates for those who did not receive this form of treatment. Although the presently available evidence shows that psychotherapy is considerably more effective than Eysenck claimed, however, the same body of research has brought out some genuine issues as to the universal applicability and value of psychotherapy. The ideal patient is someone already on the way to psychological health, with a fair degree of psychosocial competence, intelligence, personality integration, and insight. The more severely disturbed and mentally retarded, unmotivated, and many of those facing the stresses of poverty or race are less well served. Even if there were no question of effectiveness of psychotherapy, it is clearly not an efficient procedure. It is costly in time, effort, and money, and hence most available to the motivated and the affluent. During a professional lifetime, a clinician practicing intensive psychotherapy can see only a very few limited number of people. Another factor that we are going to discuss now is the lowered expectations concerning clinical assessment. Psychologists were also questioning the overall utility of assessment and the ability of clinicians to make complex judgments about human behavior. In 1954, Paul Meehl published the results of his review of studies comparing the accuracy of predictions made through clinicians' judgments versus those made by the statistical combination of test results. His findings showed that out of the 20 studies he reviewed, only one supported the seniority of clinical inference, while all provided clear support for statistical predictions. Meehl's subsequent reviews in 1957 and 65 provided even stronger support for superiority of some type of statistical combinations of assessment information over the evaluations of clinicians. In fact, other research published about the same time also suggested that specialized clinical training can actually lead to an impaired ability to make clinical inferences from assessment information. The next factor is the changing concepts of mental health and illness. More broadly, there has been widespread dissatisfaction with traditional medical concepts, particularly as reflected in the custodial but also in the therapeutic approaches to mental problems. From various perspectives, it has been argued that conceiving emotional disorders in analogy to physical disorders or diseases limits our understanding of human problems and our effectiveness in alleviating them. Of particular concern is the implication in the medical model that mental diseases reside in the individual, and hence that intervention must involve treatment of the sick person to the end of removing or altering the pathological processes within him. In opposition to such a view, many have argued the need for a social prevention, growth and development, or the general term being used here is community psychology point of view, which sees human problems as residing in the interplay between the distressed person and the social forces. Another factor is dissatisfaction with existing professional roles. Mental health professionals of all kinds, like their critics, have become concerned with their limited ability to effect important changes in the level of psychological distress in the larger community. Working in clinics, private offices, and hospitals, waiting rather passively for troubled people to present themselves for help, many have come to realize the need for a greater area of influence and for earlier, quicker, and more effective services. Clinical psychologists face the additional problem of feeling unfulfilled in medical settings where primary decisions are made by the physicians. The medical environment, many feel, provides too little opportunity to exert their independence and competence too often. They see themselves as second-class citizens in a mental health enterprise dominated by the medical men. Many see the new roles emerging in community psychology as providing a better route towards professional autonomy and allowing greater freedom to experiment with uniquely psychological interventions. The next factor is the manpower shortage. The blatant manpower shortage has been a major impetus to reconceptualize professional roles, to suggest alternate ways of deploying professional time, and to seek new workers in sub-professional roles. LB in 1959 is one of the major studies of the Joint Commission Medical Illness and Health, surveyed manpower trends in the major mental health professions. His findings led to the author and Joint Commission to conclude with frank pessimism that sufficient professional personnel to eliminate the glaring deficiency in our care of mental patients will ever become available if present population trend continues without a commensurate increase in the recruitment and training of mental health manpower. The emerging community mental health centers of the 1960s have had difficulties in finding sufficient numbers of adequately trained personnel. As the hospitals they sought to complement, they have had to compete with a number of attractive alternatives for the already short number of trained professionals. Another factor is the unequal distribution of mental health care across social class. Scroll, Langner, Michael, Opler and Rennie in a research and a survey in 1962 showed that the highest rate of mental disorder was in the lower socio-economic groups and that individuals from lower social class were least likely to receive mental health services. In other words, those with the greatest need for mental health services appeared to be the least likely to receive them. Hollingshed and Rodlick showed in their classic study that the socio-economic class also affected the type of care received by mental health patients. Among severely disturbed patients, those from the higher socio-economic class were much more likely to receive psychotherapy than those from the lower socio-economic classes. Evidence suggested that compared to patients of higher socioeconomic status, patients in the lower strata were more often treated in public facilities where they were likely to receive drug treatment and other physical interventions such as psychosurgery and ECT or custodial care. The mental hospital. Another major impetus to the emergence of community psychology was the sorry state of the large state mental hospitals by the end of World War II. When William Tuke founded the Retreat in York, England in 1972, he believed that the mentally ill, if treated humanely and urged to greater responsibility and self-control, were capable of resuming normal lives in society, a point of view which has been called the moral treatment. By the mid-19th century, however, American society changed radically, and with it the faith in moral treatment declined. Waves of new immigrants were swelling urban populations and straining the resources of psychiatric hospitals. Social historians noted that mental illness came to be viewed more pessimistically, and hospitals became more centers for custodial care than for moral treatment. Small asylums grew into vast, overcrowded, and understaffed state hospitals, often located far from the population centers, and so poorly supported that basic facilities of food, clothing, and shelter were also lacking. There are considerable gains in reducing the duration and effects of hospitalization. According to NIMH statistics, the state hospital population went from 5,59,000 in 1955 to 2,79,955 in 1972, and the trend continues downwards despite US population rise over these years. Socially oriented clinicians have contributed to the well-being of severely disturbed patients by efforts, firstly, to make the hospital environment more therapeutic for those already hospitalized. Here they can include milieu-therapy, token economy, activity programs, etc. And secondly, keep patients out of hospitals through providing community-based alternatives, that is, the community mental health programs, halfway houses, rehabilitation, and self-help organizations. Let's move on to the history of community movement. The community movement emerged in the 1960s from the professional and social climate we have just reviewed, but its root runs deep in the history of psychiatric and clinical psychology. When Clifford Beards published A Mind That Found Itself in 1908, professional and public attention was called sharply to the sorry condition of hospitalized mental patients. Shortly thereafter, a national organization was formed which evolved into a National Association of Mental Hygiene, NAMH, which worked for hospital reform and preventive programs. The term mental hygiene itself was used as early as 1843 by William Sweetser. Adolph Meyer, a leading American psychiatrist early in the century, pressed for socially oriented attacks on mental health problems. He noted that communities have to learn what they produce in the way of mental problems and waste of human opportunities. And with such knowledge, they will arise from more charity and mending or hasty propaganda to a well balanced early care, prevention, and general gain of health. By the end of World War II, mental health professionals and the federal government were ready for more definitive actions towards the improvement of mental health in the general population. In 1955, Congress passed the Mental Health Study Act, which established the Joint Commission on Mental Illness and Health to survey comprehensively the care of the mentally ill in the United States and to recommend future programs and directions. A broad base of professional and citizen groups were represented in the Joint Commission. Studies were undertaken on positive concepts of mental health, hospital care, social programs, research, manpower, and mental health economics, and among others. After receiving the Joint Commission's report, President John F. Kennedy called for bold, newer approaches. He proposed a national mental health program to assist in the inauguration of a wholly new emphasis and approach to care for the mentally ill. The traditional neglect of the psychologically disabled was to be replaced by forceful and far-reaching programs. Specifically, they were also aimed at prevention, wherever possible, early diagnosis, and comprehensive care, reducing hospital populations and developing community-based programs. The many mental health workers who felt that the Joint Commission report was too timid and conservative in its conclusions were heartened by Kennedy's message. They proposed comprehensive community mental health centers were seen as a potential vehicle for far-reaching changes. The Comprehensive Community Mental Health Center. Late in 1963, Congress passed the Community Mental Health Centers Act, which provided up to 2/3 of the funds for the construction of comprehensive mental health care centers in the communities itself. 2 years later, supplementary legislation provided additional funds for staffing needs. In order to qualify for these funds, states had to draw up long range plans thoroughly surveying needs and resources, delineating the areas to be served and the priorities for implementation. It was required that the community members participate in the planning. Each center was expected to serve a catchment area of not less than 75,000 and not more than 2 lakh people. The term comprehensive was intended to have a double meaning. All mental health services would be available to all people. A critical part of the federal legislation is that it requires centers to provide 5 essential services in order to qualify for the federal funds. The essential services are inpatient care, outpatient treatment, partial hospitalization, that is day or night hospitalization with the patient going home or to work in the other hours, 24 hours emergency services, and consultation and education to community agencies and to professional personnel. The desirable but not essential services were diagnostic services, rehabilitation and aftercare, training, research and evaluation. The concept of community mental health center in the 1963 Act had the desirable consequence of moving psychiatric care from isolated hospitals to community based centers, which more usually were located in the general hospitals. Moreover, it provided emergency help readily and locally available and encouraged consultation, aftercare services, training and research. In 1966, the APA issued a position paper criticizing current trends and proposing guidelines for the future development of community mental health centers. But during 1960s, the development of new centers was hampered by problems local communities had in raising matching funds and in recruiting qualified professionals. In contrast, the Westside Community Mental Health Center of San Francisco weathered and was strengthened in early conflicts between community and professional interests. The Comprehensive Community Mental Health Center is by now an established institution, although perhaps less vital in the total mental health picture than was originally intended. A survey of accomplishments and difficulties of community mental health centers conducted by Ralph Nader Task Force paints a fairly dismal picture. This report alleges that commendable goals are rarely achieved in practice.